I hereby welcome you all again. Thank you for being so patient with us. Going forward, may I now call Dr. Priyanka Niranjani ma'am to deliver her lecture on the etiology and pathophysiology of cleft lip and palate. Dr. Priyanka Niranjani completed her graduation from Sharad Pawar Dental College and Hospital, Savangi Mekhi Varna, and pursued masters in dental surgery in the branch of orthodontics and dentofacial orthopedics from CSMSS Dental College and Hospital, Aurangabad, followed by a fellowship in cleft orthodontics, along with a certificate course by Smile Train USA at Sharad Pawar Dental College and Hospital, Savangi Mekhi Varna. She has also done her MPhil in 2016 and PhD in 2022 in Health Professions Education from the Detta Mege Institute of Medical Sciences. She is presently working as Associate Professor in Sharad Pawar Dental College and Hospital, Vatha, member of the Indian Orthodontic Society, and the International Cleft Lip and Palate Foundation. Her clinical interests include sorry, Lip and Palate Foundation. She is presently working as an associate professor in Sharad Pawar Dental College and Hospital, member of the Indian Orthodontic Society, and appointed as a reviewer board member of Indian Journal of Orthodontics and Dentofacial Research. She is adorned with 34 publications in national and international journals. A cherry on top, she is also blessed with a great voice and has won many state level awards and also chaired state level singing competitions. Over to you, ma'am. Minus 0.75 minus 0.50.
Good morning to one and all. Uh, the topic for my today's presentation is etiology and pathogenesis of cleft lip and palate. Myself, Dr. Priyanka Niranjane. I'm Associate Professor in the Department of Orthodontics, Sharad Pawar Dental College, Dattami Institute of Medical Sciences, Deemed to be University, Wardha. Today, I'll be discussing the etiology and pathogenesis of cleft. First, we'll see the prevalence of cleft, then the development of cleft lip, cleft palate, then the need to study the etiology of cleft. Then in this etiology, we'll see about the genetics of cleft lip and palate, environmental factors, local factors, conclusion, and the references. So, what is the epidemiology of cleft or the prevalence of cleft? Now, cleft is the most common congenital anomaly which is seen in newborn. It is reported to be 1.5 to 2 to 1,000 live births and is higher among males than among females. Now, this incidence varies with the cleft type, sex, and the ethnic origin. Now, in India itself, almost 2 million are born per year with cleft. In this global map, widely spread across the globe, with more than with the prevalence of 1 is to 500 in Asians for Asian population, 1 is to 1,000 Caucasians, and 1 is to 2,500 in the African population. So in Asians, the prevalence is higher amongst, first of all, prevalence, that is 1 is to 500, and 1 is and the cleft palate is 1 is to 2,000. Then amongst the male and female, it is twice in males as compared to females. As chromosomal and teratogenic. So what is the need to study the etiology? Cleft lip and palate is etiologically heterogeneous, and this has critical implications for understanding the biology of facial development, how the environment and prognosis of individuals with these conditions. And that's why when any has a multifactorial origin, a single cause, that's why complex, and that's why if we try to understand and go into the depth of the etiology, then only we will be able will lead to a better prognosis of individuals with this condition. Etiology and the of time. Okay. As we all know, we have studied normal embryology that first, second, and third time is play a critical role in development of face, mouth, and tongue. So this embryology is created to be the fourth and phase and is the process process, two maxillary processes and two mandibular processes. As we can see in this picture, this is the picture taken. This is a picture of an embryo at 4 weeks of intrauterine life, where we can appreciate the frontonasal process, the maxillary process, and the mandibular prominence in specifically. So at embryonic day 24, the frontonasal process can be clearly identified, which is bounded on either side by two maxillary processes bilaterally that are derived from the first branchial arch. At day 28 of the embryonic life, that is at the end of fourth week, mouse. Here we can see that the medial and the lateral nasal processes which form the of the nasal placard, they so develop around 6 to 7 weeks of intrauterine life. Now we will see how the embryo appears at 7 to 8th week of intrauterine life. That is when the normal palate forms include normal secondary palate forms. So the secondary palate, as we all know, is a structure which separates from the nasal cavity from the oral cavity. The secondary palate begins development from the 6th week from projections of the paired maxillary process of the first brachial arches, which are termed as the palatal shells or the lateral palatine processes. So as you can see in the second diagram, these are the two palatal shells which are growing vertically on either side of the tongue, and this these are the two palatine shells which arise from the maxillary process itself, but initially they grow vertically on either side of the developing tongue. But now as the mandibular process, or the mandible which grows from the mandibular process, it grows downwards and forwards. Along with that, the tongue also moves downwards, and the shells, they become more horizontal and grow medially towards each other. So this is a very landmark event in the intrauterine life, that the vertically growing shells, as the tongue descends downwards, they assume a horizontal position. So if anything happens at this level, it can contribute to the formation of cleft. Now, how these palatine shells, they grow from a vertical to a horizontal position? There is an intrinsic shelf elevating force which is generated by hydration of hyaluron, which primarily causes an elevation of these palatal shells. Because of the osmotic shelf elevating force produced by the collagen fibers, mesenchymal cell orientation and contraction within the palate, the vertically growing palatine shells, they assume a horizontal direction. And once they assume this horizontal direction, the merging between the right and the left palatine shells occurs around the ninth week and is completed posteriorly by 12th week of embryonic life. So this fusion between the right and left palatal shells, it occurs mainly from the anterior to the posterior direction. And during merging, the opposed epithelia from an epithelial seam undergoes apoptosis, migration, or transformation that results in mesenchymal continuity. So imagine when the parietal shells, they grow horizontally and they fuse with each other. First of all, the epithelial margin between the two palatal shells, it grows apoptosis. The basal layer, it undergoes shedding, and then there is a fusion of the underlying mesenchymal layer or the mesoderm. So before merging, the outer epidermal layer is sloughed off, leaving the basal epithelial layer, which constitutes the medial edge epithelium, which is abbreviated as MEE, of each palatal shells. Now, the mesial edge epithelium of each cells, it approximates, and subsequently there is a confluence between the two shells. So while the secondary palate is also forming now, the ectoderm and mesoderm from the frontonasal and the maxillary process, it proliferates to form the nasal septum. And this nasal septum now grows down and forward to form the roof of the nasal cavity and fuses with the primary and secondary palate along the midline. So thus dividing the nasal cavity into two passages. Okay. Now, perturbations, if any, caused at any level by either genetic, mechanical, or teratogenic factors, at any of these steps may result in cleft of the hard and soft palate. So, how the nose forms. Now, the anterior nares are formed when the nasal pits are cut off from the stomachium by the fusion of the maxillary process with the medial nasal process. The anterior nares gradually approach each other, and as a result of which the frontonasal process becomes progressively level and its equal part ultimately forms the nasal septum. Now, the mesoderm becomes heated in the medial plane to form the prominence of the nose, and ultimately a group of layers and the bulging forebrain now becomes forehead. Now, as we on the anterior next to opposite of forwards. So eventually develop this. Now we have seen the lower is formed by fusion of the mandibular process of right and the left side. And now the growing for the future mouth is now encircled by the upper lip, the lower lip. It is very broad part. So its lateral part of the stomodeum, it is bound above by the maxillary process and below by the mandibular process. These processes, they undergo progressive fusion with each other to form the cheeks on the lateral side. So during the formation of upper lip, the maxillary process fuse with the process. So this is how the nares, the cheek, maxillary process, the upper lip, the premaxilla, and the secondary palate forms all around 4 to 12 weeks of intrauterine life. Now the fusion which occurs not only in the region of the lip, but this extends mainly from the stomodeum to the medial angle of the developing eye. So as we have seen in the previous slide that this lateral fusion between the maxillary process and the mandibular process, it not only stops in the region of the lip, but it also extends laterally from the stomodeum to the medial angle of the developing eye. And for some time, this line of fusion is marked by a group which is called as the naso-optic furrow or the nasolacrimal sulcus. A strip of ectoderm becomes buried along this furrow and gives rise to nasolacrimal duct. So as we can see in this picture that a child has this oblique facial cleft and the nasolacrimal duct is patent, which was not because of the fact that the lateral fusion was didn't occur properly during the intrauterine life. So, what is the use of studying the entire embryology of embryology of craniofacial development is that we can trace that at which step, which which process didn't occur, which led to cleft lip and palate. So, as we have seen the normal craniofacial development, failure of fusion of the maxillary process with the medial and the lateral nasal process unilaterally or bilaterally may result in unilateral or bilateral cleft lip with or without palate. So mostly if the maxillary process it doesn't fuse with the medial and the lateral nasal process, then a unilateral or bilateral cleft lip with or without palate may result. If there is incomplete merging of the two medial nasal prominences, it will result in a median cleft lip. That's because the medial and the medial nasal processes of the right and left side, when they fuse, they lead to the formation of the entire upper lip and the philtrum. So if they don't fuse, then it results in a median cleft lip. Then, if the fusion doesn't occurs between the two palatine shells, then it results in cleft of the secondary palate with varying severity, right from an incomplete cleft palate to a complete cleft palate up to the cleft uvula also. If there is a failure of fusion of the medial nasal maxillary process, then it results in the formation of oblique facial cleft. So, this is the entire spectrum of unilateral cleft lip and palate and bilateral cleft lip and palate. So, as we have seen earlier that the main thing is the fusion between the medial nasal process, lateral nasal process, which results in the formation of upper lip philtrum, and laterally the maxillary processes and the maxillary process with the medial and the lateral nasal process. So, if this entire fusion doesn't occur or when the palatine shells also don't fuse with each other, then we see the entire spectrum of how the unilateral cleft lip results. So in the first picture we can see that a microform cleft lip. This is because of fusion, because of inadequate fusion between the medial nasal processes of both the sides. Incomplete cleft lip, then complete cleft lip and alveolus, that is the cleft unilateral cleft lip is extending from the lips up till the alveolus. And then in the last picture we can see how the cleft is varying in severity. It is extending from the lip to the alveolus to the entire palate. In the second picture, we can see the spectrum of bilateral cleft lip and palate. So, firstly, there is bilateral incomplete cleft of the lip. There is, in the second picture, we can see there is microform right complete cleft lip. And the next, incomplete right and complete left cleft lip and alveolus. And in the last picture, we can see that the bilateral cleft lip and palate has extended from the lip to the alveolus and the entire secondary palate. So, the fusion defects in the embryological development or the fusion of the embryological processes at various levels and at various time can result in the entire spectrum of unilateral or bilateral lip and palate. This is another picture where we have seen especially the formation of how the incomplete formation of secondary palate can lead to cleft of the palate. So in the first picture we are seeing that there is an isolated there is a cleft in the uvula. In the second picture, there is a cleft in the soft palate. In the third picture, there is a cleft, incomplete cleft of the hard palate. And in the last picture, we can see that the entire the cleft palate is extending to the entire secondary palate. Okay, so this was due to the entire non-fusion of the two palatine shelves of the maxilla. So now we have seen till now we have seen how is the embryology and the pathophysiology of cleft. Now we will go into the details of the etiology. that why this entire thing happens, or why this cleft lip and palate and its various forms they arise. So basically there are two forms of cleft lip and palate. First is non-syndromic, and other which is syndromic or associated with syndromes. So in non-syndromic cleft lip and palate, it accounts for 70% of the entire cleft lip and palate cases, out of which 50% of cleft palate cases are associated without any anomalies, and 30% of syndromic cleft lip and 30% are syndromic cleft lip and palate, out of which 50% of cleft palate cases occur as one of the feature of any syndrome. So, what is the etiology of cleft lip and palate? Now, the etiology of cleft lip and palate is can be divided into mainly genetic and environmental factors and demographic factors. So, it actually the cleft etiology of cleft lip and palate cannot be attributed to a single cause or a single factor, but it is multifactorial, and there is an interaction, complex interaction of variety of factors. There is an interaction of genetic genes also, there is an interaction of environmental as well as other risk demographic factors. So in genetics, it's found out that there are 30 different candidate genes which have been identified in different types of clefting. In environmental factors, there is maternal smoking, maternal alcohol use, maternal nutrition, and drugs or the teratogens which lead to congenital anomaly like cleft lip and palate. And in certain demographic factors, there certain causes like maternal age, gender, and race have also been found to be associated with cleft lip and palate. So heredity. So it has been found that cleft lip and palate is transmitted through a male as sex-linked recessive gene, and the predisposition for cleft lip through heredity is 40%, while only 80 to 20% for cleft palate. Now, this cleft lip and cleft palate can be transferred as a monogenic or a single gene disorder, which conforms to a Mendelian inheritance, or a polygenic multifactorial inheritance, which shows a family tendency but not Mendelian inheritance. Sometimes this cleft lip and palate is associated with certain chromosomal abnormalities like Down syndrome, Edwards syndrome, that is trisomy 18 and trisomy D and E. So these are listed certain genes, the interaction of various genes which can lead to cleft lip and palate. So now this table shows that these are the genes which are associated with one or the other stages of craniofacial morphogenesis. So as we can see that so many genes are involved, and in the normal craniofacial embryogenesis. So if anything happens with these genes, then it may lead to cleft lip and palate. So just we can we will look very briefly into these genes, that is growth factors and receptors, in which there are so many growth factors. Then transcription factors are there, then cell adhesion molecules are there, then extracellular matrix molecules are there, then sonic hedgehog gene, which is mainly involved in induction of facial primordia and expression in the palatal mesial edge epithelium. We have earlier seen how the mesial edge, how the when the palatal shells diffuse with each other, the epithelium which is bordering these two palatine shells is called as medial edge epithelium, and mostly the sonic hedgehog gene is involved in this induction and expression in palatal MEE. Then the bone morphogenetic protein, that is BMP2 and BMP4, which are mainly present in the epithelia and mesenchyme of the palatal shells. Then MSX1 homeobox gene, which is required for expression of SHH, that is sonic hedgehog gene, in MEE, that is mesial edge epithelium, and BMP2 and BMP4 in the palatal mesenchyme. Then there is epidermal growth factor involved, which stimulates the glycosaminoglycan production in palatal shells. Then there is transforming growth factor alpha, which stimulates extracellular matrix biosynthesis. Then there is fibronectin and collagen 3, which modulate factors in hyaluronate expansion during self-orientation. Then there is collagen 9, which appears in ME cells prior to elevation and has a role in the epithelial mesenchymal. So we can see here how the different genes are involved in various processes, and any mutation in these genes can lead to cleft palate at any level. Here we see again there are these are the candidate genes or loci for non-syndromic left lip and palate, that is transforming growth factor alpha, which is present in high levels in the mesial edge epithelium of palatal shelves. Then transforming growth factor beta 1 and beta 2, which is mainly present, which mainly regulates mesenchymal cell proliferation, extracellular matrix synthesis. So these are the inherited syndromes and non-inherited syndromes associated with cleft lip and palate. The most common being them is Vanderwood syndrome. So Vanderwood syndrome, Treacher-Collins syndrome, cleidocranial dysplasia, ectodermal dysplasia, Stickler syndrome. These are all autosomal dominant syndromes which are associated with cleft lip and palate. And Roberts, Eberts, Christian, Meckel syndrome. These are all autosomal recessive syndromes associated with cleft lip and palate. This picture shows the frequency with which these syndromes are associated with orofacial cleft. So here we see that the Piri-Robin syndrome or the Piri-Robin sequence is the most common or the most frequent syndrome which is associated with orofacial. So after the genetic etiology, we now come to the environmental risk factors or the environmental factors which are associated with causation of cleft lip and palate. So the most common is maternal smoking. Honey Natal in 2007, using the National Birth Data Defect Prevalence Survey data, found that any preconceptual smoking was associated with orofacial cleft in those women as compared to those who do not smoke. And in meta-analysis from 24 cohort and case control studies from 1996 to 2002, they also found that smoking was highly associated with cleft lip and palate. So the main attribute behind maternal smoking is a depletion of oxygen. So wherever there is hypoxia or oxygen depletion in the cells, it is associated with high risk of causing cleft. Now in our Indian scenario, the maternal smoking is not very frequent and not socially acceptable. But now, in our scenario, especially in the rural cases, when the females they cook on chulhas, so there is a release of carbon monoxide gas, and that causes oxygen depletion, and that's why it can cause cleft lip and palate. So wherever there is oxygen depletion, mainly in the form of carbon monoxide or increased maternal smoking, it is associated with cleft lip and palate. Then maternal alcohol use. High levels of alcohol as in the blood of mother, especially in the first trimester, is associated with increased risk of causing orofacial cleft as compared to those women who do not drink or do not drink alcohol. So multi-center case control study which was conducted in Europe in 1989 to 1992, looking for association between alcohol consumption in first trimester, also found that there is an increased risk for CLP in mothers who have high alcohol blood levels during the first trimester of pregnancy. Then maternal nutrition. Maternal nutrition is also very important and is associated with high risk of cleft lip and palate, particularly the deficiency of folic acid, vitamin B12, vitamin B6, and zinc. Now, folic acid amongst that is very important because folic acid is involved in DNA synthesis. So, whenever there is a folic acid intake, this folic acid it is transported to inside the cells through various folic acid binding proteins and reduced carriers. Inside the cell, this folic acid is converted into dihydrofolate and trihydro or
मेरी Zoom में किसी
tetrahydrofolate
फोन कॉल क्यों हो रहा है?
dihydrofolate reductase enzyme. So, if there is a deficiency of folic acid, this entire folate metabolism is inhibited. Now, this folate metabolism is essential for the generation of thymidines and purines, which are essential part of DNA. So, if there is a folic acid deficiency, then there is impaired DNA synthesis, and that's why there is an
मेरा
increased risk of cleft lip and palate. And that's why it is said
मैं
that
तो बना रही हूँ.
prophylactic folic acid intake before pregnancy is
पता नहीं
protective
तो अभी
against
मेरा बना
causing
नहीं है.
orofacial cleft. Now there
Sorry.
is one more theory, that is Arakeri's maternal theory, which states that if there is a celiac disease due to T cell mediated
क्या नाम है
autoimmune
इसका?
response or injury causing pathological changes in the small intestinal mucosa, it may lead to malabsorption. So malabsorption of mainly folic acid, which may be symptomatic or asymptomatic. If it is asymptomatic, then there is then there can be undiagnosed celiac disease, which which is mostly higher prevalence in women during pregnancy, may lead to malabsorption of folic acid. And once again, malabsorption of folic acid can be implicated to derange folate metabolism, leading to high risk of cleft lip and palate. Then diabetes. So women having living with diabetes before pregnancy have an increased risk of having a child with orofacial cleft than women who do not live with diabetes. Diabetes has also been implicated in causation of cleft and palate. Then there are various teratogens like anti-seizure drugs, then drugs used to treat cystic acne like retinoids, or anti-cancer drugs like methotrexate. All these are implicated in causing cleft. Then maternal age also. So if the maternal age is beyond 30, that is 30 to 40 years, is also associated with increased risk of cleft as compared to those women who are in the age group of 20 to 25. Then these are all the local factors which are implicated in causation of cleft lip and palate. That is, failure of the head to elevate and become erect at around 7 to 9th week. So this is a very landmark event which occurs at 7 to 9th week of intrauterine life. That is when the head elevates. So if there is a failure of the head to elevate, it can also lead to cleft lip and palate. Deficiency of oxygen, as we have earlier seen, deficiency of oxygen in the form of maternal smoking or carbon monoxide can lead to cleft lip and palate. Then another landmark event which occurs at 7th week of intrauterine life, that is when the stapedial artery severs from the internal carotid and its terminal branches join the external carotid artery. So delay in this landmark step, it can lead to cleft lip and palate, shift of blood supply to the face, and lastly failure of the tongue to descend downwards. We have earlier seen that when the tongue descends downward due to growth of the mandible, the vertically oriented palatal shelves, they assume a horizontal position and then they fuse with each other. So if this event doesn't occurs, that is, if the tongue doesn't descend downward and the palatine shelves they do not fuse with each other, it may lead to cleft of the secondary palate. So this is a summary of risk factors for implicated in causation of cleft lip and palate. Positive familial history, that is if there is a sibling affected with cleft or any relative in a family which is affected with cleft, then the offspring has a very high chance of getting cleft lip and palate. Advanced maternal age greater than 30 years. Even increased paternal age is also implicated in causing cleft lip and palate. Then teratogens exposure, mainly benzodiazepines, phenytoin, opiates, penicillin, salicylate, cortisone, and high doses of vitamin A or retinoic acid. So this is a brief summary of all the structural and functional factors which are implicated in causation of cleft. That is, structural factors mainly inadequacy of palatal process or cranial factor like growth and size of cranial structures, and mechanical interference, that is tongue position, its timing of descent or its spatial position can lead to cleft lip and palate. Then in functional factors, if there is no secondary rupture of the mesial edge epithelium, it will not lead to the fusion of the palatine shelves. If the mesial edge epithelium does not undergoes apoptosis, or if there is failure of epithelial degeneration, or if there is inadequacy of the intrinsic palatine shelf force, which may lead to non-fusion of the palatine shelves, it may all lead to cleft lip and palate. So here now, till now we have seen about the etiology and the pathophysiology of cleft lip and palate. So we can conclude that no single factor can be attributed to the position of cleft or the etiology of cleft, but cleft lip and palate, including non-syndromic and syndromic cleft, especially the non-syndromic cleft lip and palate, is caused due to the interaction of multiple factors. It is multifactorial etiology, including the interaction of genetic as well as environmental and local factors leads to cleft. So while there is substantial evidence that genetic factors contribute to orofacial clefts, the complex mode of is less.
Thank you, ma'am, for the lecture. Your lecture has given us many points to ponder over. Ma'am, kindly accept the certificate and oblige. Thank you, ma'am. Now, proceeding further, we are already running late, so we will allow the scheduled 10 minutes break and directly proceed to the next lecture on problems associated with cleft lip and palate, for which I invite Dr. Samiksha Chopra, ma'am. Dr. Samiksha Chopra completed her BDS from Dashmesh Institute of Research and Dental Science, Faridakot in 2011. Following which, she pursued Masters in the branch of Orthodontics and Dentofacial Orthopedics from Guru Nanak Dev Dental College and Research Institute, Sunam, in 2017. Presently working as an Assistant Professor, Department of Orthodontics at Dashmesh Institute of Research and Dental Science, Faridakot. She is an accredited Smile Train Partner at Amandeep Hospital, Amritsar, as a cleft orthodontist since 2020. She is also a member of the Indian Orthodontic Society and Indian Society of Cleft Lip Palate and Craniofacial Anomalies. She has won various prizes at state and national conferences, has been an organizing member at national conferences and academic events, and has various publications in national and international journals. Over to you, ma'am.
remaining along with that, and how much it is a right decision to take care of these during the surgery, before the surgery, or after the surgery. So this analysis and measurement in the buccolingual crystal level can be easily be taken care of by the or treatment modalities. So this is going to decide on our cone beam CT how much bone width, length, and depth can be decided. So this can be very well appreciated when we have the volumetric assessment of that. So same CBCT, when the volumetric analysis is done, when able to appreciate the distal areas, the defect is more deep compared to the mesial area of the canine. This is lateral and this is canine. So this is the defect can be reconstructed.
A very good morning of you and welcome everyone to this two-day workshop on Cleft and Palate organized by CDCRI. I would take an opportunity first of all to thank the organizing secretary, Dr. Achint sir, and the scientific convener, Dr. Megha Jain, for inviting me for this presentation. The topic of my presentation is problems associated with cleft lip and palate. Let's start with it. Now, only if you could see everyone's story in life, you will realize how tiny your problems are. Let's take a look at a journey of a cleft child and see what problems they face. Now, introduction. Cleft lip and palate, they are most common craniofacial deformities to affect orofacial region. Now, these anomalies, they have multifactorial inheritance with both genetics and environment making varying contributions. They can occur as a feature of various genetically determined syndromes. They broadly classified as functional problems. They can be dental problems, oral structures, that is aesthetics, then problems associated with syndromic lens. Starting with the first functional problem is feeding. Now, as soon as the child, a cleft baby is born, the first and the foremost problem he faces and his family, his parents face is feeding. An open palate, they can affect an infant's ability to feed in many ways. First is it can have a profound effect on oral motor mechanics. Second, the ability to generate the necessary negative intraoral pressure for effective sucking is compromised. Then, difficulty with coordination of sucking, swallowing, and respiration during feeding is seen, and parental frustration from difficulty in feeding leads to a negative effect on parent-infant bonding. Second, it's dental problems. So the problems which most commonly seen, they are missing, malpositioned and malformed teeth, crossbite, mid-face retrusion, protruding with overhanging premaxilla, open bite, abnormal incisor relationships, oronasal fistula, constricted maxillary arch, poor oral hygiene, etc. So let's take a look on all of these. Starting with the missing, malpositioned and malformed teeth. The most common finding of missing teeth is your lateral incisor or canine. Now, as clefts of the primary palate, they follow the incisive suture line. So teeth that normally border these lines, they are often missing, abnormal or malpositioned. Rotations, they are most commonly seen in central and lateral incisors. Then supernumerary tooth and the ectopic tooth is also commonly found. Starting with the rotations, you can see over here, it is pretty visible that the incisors, they are completely rotated. In the third picture, you can appreciate that the 2-1 central incisor is almost 180-degree rotated. Then here in this photograph, you can see the equally tipped incisors. Now the CBCT clearly shows the extent to which this tooth is tipped lingually. Then supernumerary and ectopic teeth, they are also common finding. Then missing teeth, as I've told, lateral incisors and canines, they are most commonly absent in these patients. So the first picture shows the absence of your lateral incisor, whereas in second picture, both lateral and canine, they are missing. Then constricted narrow maxillary arch, it is quite evident, especially in the anterior segment. The arch is collapsed. It is very narrow and constricted with bunch of crowding seen. Then protruding and overhanging premaxilla, one of the most difficult thing to correct in cleft patients is sometimes the overhanging of the premaxilla is up to the level of your lower lip and is coming outside the oral cavity. So it not only poses a functional it not only poses a aesthetic problem to them, but also the function is compromised at the same. Then mid-face retrusion, very common finding seen in cleft patients. The reason because could be various intrinsic factors and various extrinsic factors like the surgical insult leads to the deficiency in the mid-face or retrusion of the maxilla, which leads to concave profile, vertical excess in the lower face, protrusive upper lip, incisors, they are retroclined, presence of anterior posterior crossbite, and narrow maxillary arch in the anterior segment. Then next is crossbite and open bite. Both are seen most commonly, but crossbite is more evident. Then oronasal fistula. Now, oronasal fistula is one of the complication of palatoplasty. So when your palate fails to repair after palatoplasty, it leads to oronasal fistula. What problems it poses to a cleft child is nasal, speech defects, hypernasality, sneezing, nasal discharge in oral cavity. Then poor oral hygiene. this case I wanted to discuss with you, which shows the extreme case of compromised oral hygiene. Here you can see, due to loss of the upper central and lateral and anterior teeth, the upper incisors, there is complete loss of vitality, which led to the complete loss of premaxillary segment, giving an old age appearance to the patient. Similarly, in the lower arch, you can appreciate that this condition is going to develop, and the child is only 14 years old. Then speech and resonance disorders. CLP patients, they are at a higher risk of communication disorders. Child having cleft of primary palate has a risk of dental abnormalities that can interfere with speech. Child having cleft of secondary palate, there has a risk of velopharyngeal insufficiency that can affect areas of speech, sound, and production and resonance. Then abnormalities of dentition may affect speech by causing obligatory distortions or compensatory errors. Now, what are these obligatory distortions and compensatory errors? The obligatory distortions, they are passive speech characteristics. So they occur when the articulation placement is normal, but due to abnormal structure, the distortion of speech sounds occur. Whereas in compensatory errors, they occur because of the misarticulations. Then skeletal malocclusion can have a far more significant effect on speech than dental anomalies. In skeletal class 2 malocclusion, the position of the tongue tip rests under the palate rather than the alveolar ridge, which can cause obligatory distortion of the sibilants. Then in skeletal class 3 malocclusion, mandible along with the tongue is in anterior position relative to the alveolar ridge, which leads to difficulty in sibilant and lingual alveolar sound production. Next is the resonance disorders. These are characterized by abnormal transmission of sound energy through the oral, nasal, or pharyngeal cavities of the vocal tract during speech production. Now, resonance disorders, they include hypernasality, hyponasality, cul-de-sac resonance, and mixed resonance. Here, I would like to share a speech disorder video presentation of a child, 22-year-old. Let's listen to her voice.
दादी दूध दे दो, टिक्कू का टीवी टूटा, टाकिया डाक डालो, चाचा चाची चलिए, राजा जल्दी जाओ, एक काला कौवा है, गोलू गीत गाओ, पिता 60 पैसे दो, कोयल ने क्या गाया, मामा मामी आम लाए, बिस्की वेफर दो, फूफा फल फूल लाए, ओलू भालू भागा।
So, on giving her speech therapy, we got her nasoendoscopy done, and what we found that the patient was suffering from BPI, that is velopharyngeal insufficiency. So let's discuss about this in my upcoming slide. What is velopharyngeal insufficiency? So now we have velopharyngeal dysfunction. It occurs when there is an abnormality in any of these three components during speech production. Now, three components are: first is that there is abnormal velopharyngeal learning, so it leads to velopharyngeal mislearning. Second, if there is an abnormal anatomy, it leads to velopharyngeal insufficiency. Now, what is abnormal anatomy? What happens that due to the abnormal anatomic structures, the velopharyngeal closure is inadequate. Whereas the third component, which is the incompetency. Incompetency means when due to abnormal neurophysiology or because of the weak neural response, the adequate closure of the velopharyngeal is not achieved. So all these things leads to, it has its effect on speech. It leads to hypernasality, nasal ear emission, obligatory distortions, compensatory errors, as I've explained earlier, dysphonia, difficulty in speech. Then effect on language and cognition. Now, association between cleft and language or cognitive development is more evident in syndromic cleft children. Risk is high in these patients because of the associated brain anomalies and neurological dysfunction. Now, children with non-syndromic cleft, they are at higher risk for early delays in both language and cognition development, but they disappear with time. Then comes the psychosocial problem. Now, starting with the family issues, as the child is born, cleft child is born, there is a setback to, there is a great shock and a setback to the entire family, especially the mother. What happens is that the mother of the child is undergoing a psychological setback. At the same time, she is going into depression. She is facing so much issues from the family side. Sometimes the child and the mother is not accepted by the family. We have a number of cases in which the child and the mother, they are left by the husband and the in-law family. The parents, the grandparents, they don't even come to see the child. They don't want to see the child. They just leave them. So these family issues, they start right after the birth of a cleft child. Then as the child proceeds, grows up, goes to school, further problems, what the child faces are social interaction. Various studies, they have shown that a child at the school age has less number, a cleft child has less number of friends as compared to the normal counterparts. Why? Because of low self-esteem of the child, low confidence of the child. This child does not interact much with the with its peer friends. Then learning ability. Many patients, we have seen that the learning ability is compromised, especially in syndromic cleft patients. Then third is teasing. When you are in school, the cleft child is most commonly bullied by his batchmates, his classmates, and that further, this constant teasing in school leads to the lowering of the morale of that patient, of that child, as well as the self-confidence is reduced. Then self-perception. All because of these first three factors, the child starts perceiving that he is not acceptable in the society, or in not acceptable by his normal peers. The next, societal issues as the child grows up, physical attractiveness, speech quality, hearing impairment, all these are the societal issues which a cleft child faces. Then effect on facial and oral structures, that is aesthetics. A child who's born with cleft and craniofacial anomalies, they have issues with both the aesthetics as well as function. They can be affected by acquired diseases, conditions of face, ear, nose, throat, that would further interfere with the function. So let's individually see what problems they face. Starting with the ear. So most common feature is microtia, which is seen in a syndromic cleft child. One of the syndromes, that is hemifacial microsomia, poses this common finding of microtia. Then auditory atresia, which is a closure or absence of the external auditory canal, which what happens that it leads to impairment in hearing. Then children under the age of 3, they are more prone to the acute otitis media, that is the ear infection, and repeated ear infections poses another potential complication of sensory neural hearing loss. This is a case reported to us with the hemifacial microsomia with treated cleft palate. Here you can appreciate the microtia, that is the improper formation of the malformation of the external ear. Then nose. Cleft of the primary palate, it often causes asymmetry of the nose and reduced projection of nasal tip, which affect aesthetics. Now, anomalies of the inside of the nose often affect the function, in particular, breathing and resonance. Other nasal anomalies include unilateral or bilateral piriform aperture stenosis, which is narrowing of the piriform aperture, which may lead to breathing issues. One such case was reported to us 2 years back. So, a patient of ours at the age of 8 was having severe breathing issues, which got increased more in winters. So, we need to undergo immediate septorhinoplasty for that patient. Then, problems associated with syndromic cleft. Now, most defects, they're isolated birth defects. Some are caused by underlying genetic syndromes or conditions. It has been estimated that more than 400 distinct syndromes, they are associated with facial clefts. Syndromes, some of the syndromes I've listed down, which are commonly associated with cleft lip, with without cleft palate, and with cleft palate only. Then what problems a syndrome cleft child faces? So there are so many anomalies listed, anomalies of the tongue like macroglossia, microglossia, ankyloglossia, then anomalies of dentition and occlusion, as I've already discussed, like cross bite, open bite, then anomalies of mandible, like bird face deformity is common, micrognathia, then anomalies of facial bones, which includes malar deficiency, mid-face deficiency, then anomalies of cranium, which includes dolichocephaly, holoprosencephaly, brachycephaly, then anomalies of ear, as I've shown, microtia, atresia, then anomalies of eyes, which includes hypotellurism, coloboma, then anomalies of nose, which includes, as I've deviated septum and stenosis of the aperture. Then anomalies of fingers and toes includes clinodactyly, syndactyly. Then cardiac anomalies, so like atrial septal defect, tetralogy of Fallot, ventral septal defect, etc. Now, I would like to conclude my presentation with one of my case. I would like to discuss about this case. This child is 9 years old, and what problems he's facing. He's facing a bulk of problems right from the birth. First of all, going on to intraoral, you can pretty see if there is presence of oronasal fistula, malalignment of incisors, central incisors, extremely poor oral hygiene, highly compromised oral hygiene, condition of the oral cavity. Top of it, there is fusion of upper lip and premaxilla. No sulcus is present at all. No mouth opening is there, and the elasticity around the oral structure, the lips, is very negligible. You cannot even open, you cannot put a cheek retractor as well inside. Coming on to the major part is he's a 9-year-old boy with a congenital heart defect and has got atrial septal defect cardiac patch closure in June 2020. The upper lip and the premaxilla is completely fused. And if we're coming on to this OPG of this patient, almost no dentition is present in maxillary arch. So this not in this patient coming with so many problems, not only the aesthetic is compromised, function is compromised. We have to think a lot of procedures are to be conducted, thinking about the atrial defect, atrial septal defect the patient is suffering from, then the mental trauma, what the child as well as his family is going through. So in the end, I would like to say that challenges are what make life interesting for doctors, for orthodontists, for surgeons, for speech pathologists, but overcoming them is what makes them meaningful for these cleft children. Thank you.
There can be a considerable functional, social, and emotional toll associated with the problem of cleft lip and palate. Thank you, ma'am, for bringing our attention to these. Kindly accept the certificate, ma'am. Thank you. All the questions that the participants may have regarding the lectures will be attended to in the interactive session at the end. Now, moving forward, we have been introduced to the topic of cleft lip and palate well enough, have seen its etiology and pathophysiology, and also the problems associated with it. It's a famous saying regarding diagnosis: the eyes don't see what the mind doesn't know. With this in mind, I would like to invite our next dynamic speaker, Dr. Mahendra Patayat, to deliver his lecture on recent advances in diagnosis of cleft lip and palate. Sir is an eminent oral diagnostician and an outstanding radiologist. He completed his BDS from Government Dental College, Mumbai, and Masters in Dental Surgery in 2002, following which he went on to secure PhD in Dental Sciences. Dr. Patayat started his career as a lecturer in the year 2003 at GDC and is currently working as in charge professor, PG guide, and PhD guide in the Department of Oral Medicine and Maxillofacial Radiology, SMBT Dental College Hospital and Research Institute, India. He has to his credit more than 35 publications in various national and international journals. After successfully attaining the 3D imaging and CBCT workshop at Singapore, Dr. Mahendra sir, a first PhD in maxillofacial radiologist in imaging guided implantology, efficiently runs an exclusive 3D cone beam computed tomography diagnostic center alongside an established multi-specialty private practice in Nashik since the year 2003. He completed his training on advances in dental imaging in Germany and has been appointed as specialized certified CBCT trainer from India by Sirona Dental Academy. Recently, he has been appointed as trainer for Digital Aesthetic Dentistry Diploma Program of University of Argentina with International Association of Interdisciplinary Dentistry. Dr. Patayat is currently the editor-in-chief of the International Journal of Dental Practice and Medical Sciences, recently awarded as Most Provocative Academician of the Year 2015 by Guidant Delhi Research Excellence Award 2020, and has to his honor lifetime membership and national convener for activities of the Indian Academy of Oral Medicine and Maxillofacial Radiology, and active membership to the Indian Dental Association of Nashik since 2003. He also holds a dual membership of American Dental Association and European Academy of Dentomaxillofacial Radiology. All over, it makes Dr. Patayat an awe-inspiring personality, a benevolent doctor, a dedicated academician, and an ardent sportsperson, an example to emulate for the youth of the day. Over to you, sir.
Hello friends, welcome to the next session of today's workshop, that is recent advances in the diagnosis of the cleft lip and the cleft palate. Before going in the detail about the particular topic, let me congratulate the organizing committee members who has taken efforts to take such a challenging topic as far as the CDE program is concerned. And also, I would like to wish them a good luck for this complete next 2 days for this particular session. Starting with the recent advances, as far as diagnosis of the cleft lip and cleft palate, which is the morphological disorder or can say the developmental disorder to diagnose on the particular imaging technique. Today, I'm going to cover the topic which is more close to me as I'm working on the third dimension of radiology, that is cone beam computed tomography. As I have already said, the third dimension means where the three-dimensional picture of a particular pathology or disorder you can able to see or diagnose or analyze more clearly. This particular today's session will try to cover in the three separate steps. First, introduction to the cone beam computed tomography, how it works, how the third dimension is useful in diagnosing the pathology. Then second, about the cleft lip and cleft palate classification, because the extent of the morphology of this particular disorder need to be understand first. Then it will be easy for us to diagnose the extension on the cone beam computed tomography. Then with the help of diagnosing these images on the cone beam computed tomography, we are going to develop a 3D printed stereolithographic models, that is 3D printed models for the analysis by the surgeon who is going to operate the particular case, and obviously for the education purpose for the patients, because going for huge surgery for correcting these fascioskeletal abnormalities, it's mandatory for operator to know the details. At the same way, the patient education is needed. This is one of the next stage of the diagnosing the particular developmental disorder, where the patient will be convinced and get the details about the procedure. So first step, cone beam computed tomography. Starting with this introduction part, cone beam computed tomography or CBCT, which is developed as evolutionary process in the computed tomography for obtaining the three-dimensional information of the craniofacial structure. As we are very well aware that medical CT, that is computed tomography, is used for the complete body pathology analysis, but cone beam computed tomography is useful in the dentofacial areas. This is the same as that of the OPG. The machinery is same as that of the OPG, where the patient stands comfortably and we can construct the image out of that. Even though the technique used in the cone beam CT has been applied in medical imaging since 1982, the technological transfer of the cone beam CT to dentistry first occurred in 1998. So though it has been widely used in medical faculty, recently it introduced into the dentistry, and as cone beam technology provides external imaging at reduced radiation doses and as of the lower cost that of the medical CT, it is having the advantageous in diagnosing the pathologies. Cleft lip and the cleft palate is a true 3D facial deformity, as deformity is in the three-dimensional, that is having the length, width and depth. So it could be assumed that 3D imaging would provide a better insight into the anatomical condition as far as diagnosing this cleft lip and cleft palate. Just have a look of this particular same machinery that of the OPG. Just have a look, the object, the patient is stable, and this is the X-ray source through which X-ray radiations are travels to the area of the interest, and they will be capture on the opposite side where the image receptors are there. So object is stable, X-ray source and image receptor are synchronizing and rotating around the patient cell with a cone beam formations. So what is this cone beam and fan beam? So cone beam is generally used in head facet area where you can able to get the slice of the particular pathology or particular area of the interest, and that will be located on the image receptor. Whereas the fan shape, which is generally used in the routine medical tomography, it has the limitation, advantage and disadvantage also, but we'll not go in detail about that advantage, disadvantage. We'll just try to stick to our topic, that how the cone beam CT will useful in diagnostically useful compared to the other technologies. Simple acquisition of the image. As CT, X-ray tubes is having a particular stable areas. Image detectors also are stable. They are rotating, synchronizing around the particular gantry where patient is in supine position. So helical acquisition is there. many resolution of the fan beam, and you can able to detect the number of slices in the CT which reconstruct to form a particular image. Whereas in CBCT, that is cone beam CT, the X-ray tube and the X-ray detector are rotating, synchronizing in one direction around the patient's head with the same that of the X-ray tube and detector also rotating around the patient's head where the patient is stable, patient's head, and approximately 180 to 360 revolution around the patient's head, and we can able to detect the particular image on the area of the interest, and you can see that flat detector, the X-ray cone beam image will be seen. These images, when we got that on the monitor in the different software, you can have that raw data of the fan shape CT, that axial slice are reconstructed to form the image, whereas in cone beam CT, the particular image acquisitions, that is data of the cone beam area seen in the different slice as an 2D projections, which then reconstructed to form a particular pathological image in a 3-dimensional. So as these technical things will start with the image reconstruction algorithm, that is filtered back projection, that is FDK in the monitor, and we can able to see the images more clearly. As advantage in yes, CBCT thinner images are there compared to the CT where the thicker images are generated, which club to form a particular pathological areas. That means thicker slides compared to form a particular reconstructing the area, whereas thinner slides of the cone beam CT will reconstruct the image more clearly. So thinner the slides, more accuracy of the pathology can be detected. So as far as cone beam CT, when the principle is acceptable, how it will be useful in particularly cleft lip and cleft palate areas, there are certain guidelines. ALARA, very well aware by all of us being working with the radiology, as low as reasonably achievable. That means minimum dose, maximum diagnostic quality, which can be possible with the 3D imaging of this CBCT, where the less radiation dose has good applicability as far as these CLP patients, that is cleft lip and cleft palate patients. The published literature, scientific support for this particular statement that on the treatment outcome in the patients with CLP suggests that the important information may be obtained through the cone beam CT imaging as compared to the other imaging modalities. Scientific evidence also prove that the use of cone beam CT altered diagnosis and improves the treatment plan in CLP patients. Also, the available evidence implies that CBCT imaging in CLP patients provides a good diagnostic tool for quantifying and analyzing the surface and the deep craniofacial structure. That means the surrounding structures needs to be evaluated more clearly, and that can be very well achieved with this particular CBCT. As a scientific support by the different scientists, the recent improvements as new machinery in the CBCT, which has a different additional features. For example, resolution, septal resolutions, soft tissue contrast, specialized reconstruction algorithm, along with significantly reduced radiation dose, it makes a preferred radiation technology for the choice in detecting the extent of this particular developmental abnormalities. All available guidelines of American Board of Maxillofacial Radiology justifies the use of the cone beam CT in particular CLP patients. So CBCT is preferred over the use of CT images for the lesser radiation and comparatively lower cost. Radiation 300 times less radiation cost wise, though the cost is little bit different in the different areas, but we can definitely have lesser cost as compared to the medical CT. But here exposure parameters need to be taken into consideration when CBCT is used, as it uses a lesser exposure to the patient. So all 3D imaging tools for the assessment of the soft and skeletal tissue in the patients with or without facial clefts are quantitatively analyzed, and CBCT has given the highest quality score. When we are deciding the particular technology, we need to have some scientific support to go ahead with this. So we are discussing certain points about the cone beam CT application with the area of the interest. The cleft of lip or alveolar processes and palate is most congenital defect affecting the face. This was introduction of the CBCT. Now we are moving about the cleft lip and cleft palate, which we have already seen some in previous session, but just introductory part for that. It occurs at any time of early embryogenesis as a result of disturbed differentiation of the primordial cell layer and is associated with genetic and environmental factors. The most severe type of the defect is complete cleft of the lip, alveolar process, and the palatal areas involving the soft palate, also hard palate and soft palate, unilateral or bilateral, which leads to impaired breathing, sucking, swallowing, chewing, hearing, and speaking. So these are the all things of the affected persons are affected. So early detection and very well management of the cases is needed. As the primitive palatal forms, the frontonasal process forms the premaxilla, palatal process from the maxillary process, and the soft palate. This is some embryological part which we can aware of how the palatal areas and the soft palate areas are formed. Why we need to know about this? Yes, embryology, if it is clear, we have the clear picture of what anatomical areas we are diagnosing on the third dimension. 2D dimensions are quite very well acquainted with our eyes, but as far as this particular area in the third dimension is concerned, we can able to diagnose that more clearly. And when it comes to the defect, we have classified that defect for our understanding by knowing the embryology, like palatal process in the 7th weeks, how they forms, then palatal process at the 8 weeks, at the 10 weeks. So something goes wrong here in the soft palate area, hard palate area, or bone area, or lip area, that giving rise to something as a cleft, and which will be diagnosed as a developmental disorder as far as diagnosis is concerned. So we are stick to this particular anatomy where the palatal area is more clearly seen, and we are more concentrated if any defect unilateral, bilateral, completely, partially, or dividing going in the posterior area. So this particular anatomical structure we need to diagnose on CBCT. That's why how the structure will look from below the area. This is foramen magnum. So from below how the areas can be seen, because the beauty of the CBCT that we can able to move the particular image in any direction. We can reconstruct that, we can section that, we can see the thinnest portion, we can go travel inside the particular skull area and see the pathology. So our area of the interest will be particularly these maxillary areas and the palatal bone areas. What we look for, what you should look for when it comes to the particular pathology to detection. So this is something which you can observe on the CBCT. So this is from the frontal area, that is facial structure. This is from the lateral aspect, and this is from the below or above. This is axial section, we can label it as. So coronal, lateral, and axial section. From all these 3 dimensions, we can able to see the particular developmental defect. And as an CBCT image, this is reconstructed image where we can able to see this particular pathology from the front side, where we can able to see the maxillary sinus, posterior area, that is molar teeth, and the nasal area. So any defect or difficulty is there, we can able to make it out that in the different areas, in the different sections. So this section has taken at the molar level. So behind molar or anterior to the molar area, we can able to diagnose the pathology more clearly. So this is the same structure seen from the front side as a CBCT image before reconstruction. This is from the below, that is foramen magnum areas, and when we taken the section at different area, check it out. This particular section is taken where the mandibular area something is seen, then posterior most area sinus is just started in this area. So from the above anterior nasal spine, this is palatal bone area. So any pathology can be detected in this area. We can reconstruct and see over here. Same way, the lateral aspect of this particular thing can be visualized on the CBCT like this, where you can able to see the particular palatal bone more clearly, if any defect in the nasal portion is there, and you can also able to see the pharyngeal airways. These are pharyngeal airways play a major role in development of the face as maxilla and mandibular area. So whatever the deformities is there in the palatal bone, that can be analyzed very well in all the directions and in all the dimensions, and you can have the slice thickness as good as 0.006 to 8 millimeter, 0.008 millimeter. So that is possible to have the thinnest section, not to miss any areas when it comes to the diagnosis of the particular pathology. What to look for CBCT when it comes to the cleft lip and cleft palate area? there are a lot of structures are there surrounding this area. So what we need to see orthognathic surgery you plan, any morphology is there. So as an diagnostician, when looking at the CBCT, this anatomical structure you are looking for. Generally, we are looking for that whenever there is a pathology, but in particularly when it comes to the CBCT, we are supposed to look for the extent of the particular defect into all these structures. For that, we'll have the classification criteria. I mean, we can able to explain the involvement of the lip, involvement of the alveolus, hard palate, and soft palate in this direction. So this particular nomenclature will help us in deciding whether right side is affected or left side is affected, whether only lips are affected or alveolus is also affected, whether hard palate is affected and extend to the soft palate is there. So we have the different criteria, like when the unilateral area left side only the lips are affected. When figure B is considered, lip is also affected, hard palate is also affected on the left side. So similar way you can able to identify as a schematic presentation when whatever the pathology is involving. No doubt, this is useful when clinically you can able to diagnose the pathology and roughly make the guideline. Okay, whatever the structures are involved, we can label them. But what about the extension? That means to what extent this particular defect is seen, because we need to correct either by giving the bone graft, looking after the bone graft clearance or bone graft pathology, sorry, bone graft, how it going to respond to our treatment, how much millimeter of the graft is needed, how much resorption is needed possible in the future. So these calculation may not be possible when conventionally you look for these clinical classification. No doubt we can able to see that how much extent of the deformity is there bilaterally, unilaterally, soft palate, hard palate is completely involved. But when it comes to diagnosing the exact extent, it needs a three-dimensional picture where CBCT plays a vital role. So CBCT will allow us to do the assessment of the alveolar defect, bone grafting if needed, alveolar bone thickness closer to the tooth which is having the defect synchronization. That means some, for example, if in between the canine and lateral incisor there is a cleft palate, so how much bone is remaining into the bone socket, that is mandatory to see. Morphometric analysis of the ciliator vesica, because sometimes you need to go for the analysis like software analysis with the orthognathic surgery or cephalometric analysis, where these anatomical points are make a much major role in diagnosing and reshaping the areas. Assessment of the facial asymmetry, maxillary morphology, mandibular morphology, soft tissue thickness assessment is quite possible with the cone beam CT. Assessment of the pharyngeal airways. If in future we require the surgical planning, is it possible to do the orthognathic surgical planning well before? Yes, if you have the good cone beam CT images, we can do that. If defect is involving unilateral palate, do we require the maxillary palatal expansion as a reconstruction to develop the occlusal path for the future? Yes, it is possible. Assessment of the sinus, because sinus is the one of the structure which is having the close approximation to all the palatal area, nasal area, and then assessment of the nasal morphology, adjacent tooth morphology, or any other incidental finding. So all these structures as anatomical landmarks we already know, but we are going to assess that thoroughly analyze this particular developmental defect where the lips as a soft tissue shadow, palatal area, hard tissue, and a soft palate. These are the extension and deformities can be visualized on the community by the assessment of all these structures. How we can do that? We'll go by step. First, assessment of the alveolar bone morphology. Check it out this particular structure. We have taken the section of the particular maxillary bone. These are the posterior teeth, and you can see this canal opening. We are looking at the maxillary teeth from the below. That means the crown. We are to see whether defective. This is radio opacity bone is there, radiolucency something abnormality or soft tissue there. So it will give the brief idea which are and what is bilaterally seen the complete or incomplete. have the option to reconstruct how we can construct that more clearly. The unilateral area, how much bone has been damaged, with how much bone is needed, how much we can see from the front side, from the back side, bilateral palate, how you can see the bilateral reconstruction is possible, how it will look, how we can have the how much bone structure is needed to take the support. This can rule out and axial sections are taken at the different levels to see the extent of the pathology. This is, you can see the soft tissues are here. Here soft tissue is involved, but at the palatal bone is more thicker. Here the palatal bone is appearing to be less. Again, palatal bone is involved, but in between bilaterally soft tissues are seen. So these are the section of the same patient taken at 3 meter, the 17 mm junction, 6 millimeter, and the apical area. So the particular defect, extent of a defect from the reach area to the deeper area, to what extent it is involved, that we can able to see more clearly. Then coming to the next, as far as buccal and lingual portion of particular tooth in the nearby pathological area. Remember that this is something, the lip is also affected and the tissue is also affected. We are able to check how extension of the buccal and lingual areas can be seen, and how we can appreciate at the cement to enamel junction how much bone thickness is remaining. So whenever there is a mixed dentition, it's mandatory, because yet this particular tooth apex is not yet formed. So how much bone is needed for the development of this, and whether it will be wise decision to keep this tooth in the line of treating cleft palate and cleft lip areas, that also will be decided. So alveolar bone morphology is very well analyzed with these particular small thicknesses in the CBCD. Crystal area bone, that is for the deciduous tooth whenever it is erupting. So now we have the cleft lip and cleft palate diagnosed at early stages where the mixed dentition stage is there. So not only the hard tissues and the permanent tooth, but the developing tooth needs to be analyzed at crystal level. Bilateral, that is the buccally and lingually or palatally, how they will analyze and how much bone is remaining along with that, and how much it is a right decision to take care of these during the surgery, before the surgery, or after the surgery. So these analysis and measurement in the buccolingual crystal level can be easily be taken care of at initial level. Take it out this bone support at a different level. So this is almost completely formed tooth. This is stable, or you can see the fixed tooth without having any mobility, any pathology. So at cervical area, how much length it has been gone, whether it is vertically placed, slightly procline or retropline. In future, if needs and assessment of the alveolar bone is mandatory. How much bone thickness is remaining, on that we are going to decide. And you can appreciate 1 millimeter, 2 millimeter, and 4 millimeter level. We can able to see how much millimeter bone height, bone width is available here. So 0 millimeter cervical cement to enamel junction, just below 1 millimeter, just below 2 millimeter, just below 4 millimeter. So these are the different sections are going to give us the alveolar bone support in the unilateral or bilateral cleft palate areas. At different areas, schematic diagram, these define us the cement to enamel junction to the bone level. So this much of the bone is not there. So do you think that it will help us in taking care of the any other morphological changes or treatment modalities? So this is going to decide on our cone beam CT how much bone width, length, and depth can be decided. So these can be very well appreciated when we have the volumetric assessment of that. So same CBCT, when the volumetric analysis is done, we are able to appreciate the distal areas, the defect is more deep compared to the mesial area of the canine. This is lateral and this is canine. So this is the defect can be reconstructed as how much deep it is, how much cement to enamel junction area has been separated, and at apical area, sorry, at the incisal area, and in between the apical area, how much distance is remaining. So this defect analysis can help us in deciding which type of the bone support or bone graft is needed. So this defect as a preliminary result, we can give the guideline in deciding the surgical approach. Then if we are going for the bone graft in these particular defective areas, these areas can be analyzed in the measurement, and we can able to decide that much of the bone graft in this area, and post operatively we can analyze, okay, this particular tooth No need to remove. It is erupting tooth. A tooth has not yet been formed. The particular tooth at the cemento-enamel junction has the good well support of the tooth. Why not to support with the bone graft? And it's quite possible to support with the bone graft where slight eruption in this area will be started. So this analysis will be done in very well in advance. Now the certain these patients preoperative and postoperative bone graft, when the bone graft is given, able to appreciate these healings with the eruption of this teeth. And after 1 year, you can assess the secondary alveolar bone grafting in this particular area. So this is when it comes to the cone beam computed tomography. The next is assessment of the bone resorption. No doubt how much defect is there. We need to analyze if there is any resorption. Will our treatment modality going to help in deciding that? So yes, it is the defect where this much of the bone graft is needed, and at post-operatively how much we are able to reconstruct that area after the bone grafting. So these are the scientific calculation. So where we are going to use the how much secondary alveolar bone grafting is useful in such cases. If we look for the labiopalatal depth in the particular defect in the alveolar ridge, if it is a fair ridge or the bone support which is appreciated on the CBCT at the particular section where the palatal bone is also affected, but is it going to give the favorable result as compared to the bone which is having the good quality bone of this much of the thickness? So the supported bone will give the better result as compared to the so the bone running in these areas can assist very well in the cone beam CT. Nasal floor analysis, yes, of course, because nasal floor is having the supporting areas where the nasal floor get perforated as palatal areas is involved. So erupting canines or nearby DST, how they are going to help us if we are going to grafting in that area and how the defect is going to cover. So they also take a mandatory decision on CT. As I say, the pharyngeal spaces. This is the analysis on the software. The particular age group, as age grows, the pharyngeal airspace is having the particular third dimension volume. So we can able to see this oropharyngeal space along with anatomical structure to the nearby areas, defining the exact location and see the volume whether it is normal or abnormal. And we can decide the patient's posture according to that and do the treatment. Same way, when the patient is having the cleft in the particular maxillary area where the intermaxillary distance is this much, and we can see that almost lower arch is trying to compensate with that. Is it possible to do the expansion of these areas? So we can have the volumetric analysis of these and the palatal area. You can appreciate this particular occlusal pattern on the left side, and on the right side you can just see. I'm just saying that this is they just appear to be collapse. So we need the expansion of the sinus, and this is very well decided well in advance how we can going to analyze this, whether it require the grafting then expansion or expansion and then grafting. These are the clinicians call which able to appreciate during the cone beam CT. Sometimes the volumetric analysis of the sinus is needed, whether a facial, you can say the unilateral facial deformity will not allow us to treat the more clearly. So that 3D reconstructed sinus in the pyramidal shape can be able to appreciate very well. Also at the same time, we may require some pre-surgical approach at the surgical simulations, like the lower jaw is very well seen, but the cleft operated or before or after operated, this segmentation can be taken care of well in advance, and cone beam CT will definitely help you in deciding this. So these are the different areas where the anatomical landmarks we are aware of, and then how we are going to diagnose these particular pathologies, and we can able to appreciate that on the particular cone beam CT with a good image qualities can be seen very well. But the question is, if we are deciding how much bone graft is needed? If first and if we are planning to go for that, we have the dimension on the 3D scan of the defect of that much of the defective bone we can use as a bone graft, and the evaluation of the donor site can be easily done by taking the one scan of this area and taking the bone from this as a graft and the usability. So this is again one advantage as a treatment modality, and this is decided at the diagnostic level. So this is the application of the CBCT where we can analyze the morphology of the surrounding structure and decide the treatment modalities for the future. But how we are going to use that? Because what we have seen on the CBCT, that operator knows, that doctor knows, they are very well known that these are the things which we are going to operate. But when it comes to the communication with the patient, it is mandatory for patient to explain that this particular patient of this particular cleft requires this particular type of the treatment. So how is it possible? Is it possible to show that in the patient's oral cavity and get convinced? No, it is not possible, because the patient's deformity and pertaining to that deformity, how we are going to treat that? Do we have any option to take that CBCT as a physical model? Yes, we have. So just as an introduction part, how we are going to use the digital dentistry as a 3D printing new era as a treatment modality, where simulation of the model and printing of the model can be possible with this 3D printing technology. What is this 3D printing? So achieving the patient's and parental expectation in the treatment of the cleft condition is depend definitely on the education about the deformity, how we are going to address that deformity, and how we are going to explain that plan intervention and potential outcome. If it is possible to explain the patient in very well advance before the surgery, not virtually, but actually how we are going to do that. So the pre-operative and post-operative photographs, what we generally taken with another patient, same operated, we cannot show that to the patient because maybe the defect will be different. So at times it honors, but understanding of this complex issue needs the patient's model. So the physical models are there, having the potential advantage over the 2D imaging, over the 3D imaging, and it can give the understanding of the condition and their treatment more clearly. So here, the role of the 3D prototyping is come. So these are previously only obtained by the alternate casting, taking the imaging, 2D imaging, and if possible, the new physical format of the model can be open up to see the condition more clearly. So the possibility of the dummy or a suite of the modular 3D models of the cleft condition using the variety of the material, having the different properties, and using the several different printers, we can able to replicate the same pathology in a physical format. So once this particular 3D model is decided or printed, or it is in the physical form, the effectiveness will be more clear in understanding and assisting the clinical situation. So here comes the physical models, which helps in the patients and training the education about the cleft lip and palate condition. So now it's possible to design the lip, the cleft lip, the palate anatomy with the additive manufacturing technology. So this is something addition of a particular material which gain a particular design or shape of an object. So it will help you in deciding the exact anatomy and treatment modality on the particular model. So the concept of 3D printing is attributed to Chuck Hulk, a pioneer in the process known as stereolithography, who in the early 1980s used the photopolymers which harden or cure by the ultraviolet lasers to additively build the object in the layers. So one layer is designed, it get cured, one more layer is designed. So by layer deposition of the anatomical structure which is seen on the computer as an DICOM format, we can able to get the physical form. Over the time, the application of this 3D printing advances, including medicine and dentistry. What exactly we are doing? We are having the different scan of the particular patient. Soft tissue and bony structure we can able to separate. That means teeth we can separate, bone we can separate, and the soft tissue surrounding we can separate. That is called as a segmentation. That can be possible in digital 3D models. Then the soft tissue layering can be manually prepared with the silicone, and we can able to take the one more scan of the particular areas. So that's mean the particular pathological areas, we can have the model and we can take one more scan of that if possible. That is the initial method. So we can have the segmented soft tissue. We can have the different materials which is having the same softness or rigidity that of the soft tissue surrounding the hard tissue. So we now have the all possible materials. Now we can go ahead with this. We can able to reconstruct these materials in the particular format as a bilateral cleft. So extension can be easily visualized. Unilateral cleft, this can be easily visualized. This is the silicon manual prepared material where we can decide how we are going to close this particular area for the benefit of the patient. Also, if we have the particular scan of a patient, we can use the soft tissue and bony structure segmented with the help of the software, that is materialized software. Then we segment the tissue by reconstructing the 3D model, and then the soft tissue overlines are manually molded, or we can directly use that in the software on the CBCT scan. So this is basically a method which is we are doing virtually by using the CBCT DICOM data. And this includes the parts of the oral cavity which are scanned in the CBCT, including the tongue, uvula, soft palate, and the pharyngeal wall. So these soft tissue models are scanned using the CBCT, and you can create the 3D model. And then the bone is printed in a solid format by the Strategy 3D printer. Soft tissue, either facial, skin, soft tissue, are handmade, or we can use the soft materials using the 3D printer that is of the Strategy to take a print of these soft tissue types. Recent advances of the 3D printing is that now the human beings are trying to print the exact of the functional heart of a person. So the material is of the soft, that is cellulose type. Still R&D is going on, but days are not away that we can able to print a 3D model of a particular heart which will be in the functioning format. So when we look after the 3D model of bilateral cleft lip and cleft palate, we can appreciate the heart tissue. This cleft palate area, how we are going to reconstruct, and this is the surrounding soft tissue areas of a particular patient. So now the same patient suit models showing the skin, the bone, and the palatal components which are connected by some metal magnets in this, and we can able to explain or educate the patient, and the surgeon also can be appreciate to what extent they want to treat this. Take it out another example where you can see the bilateral involvement of the cleft lip and cleft palate, where you can appreciate these particular 3 components showing the skin areas, then the bone areas, and the palatal components which are connected with the metal. So we can able to explain that more clearly, where you can see the skin, bone, and palatal area. This is example. Isolated only cleft palate. There is no involvement of the bone, no involvement of the lip. But as we are going surgical approach, we can able to explain the patient and get the more guidelines regarding this once we are having this stereolithotropic 3D printed model, which are generated in the 3D printer by the cone beam images. So this is a possibility that the small magnets are used to components and the soft tissue and the bone separately, and they can fit with each other, and the normal bones are created which will allowing to explain about the soft tissue, hard palate, soft palate, and pharyngeal wall. Sometimes it may not be possible to see area in one model, so we'll just take one sagittal section of that model where you can appreciate the particular tongue position, then uvula going posterior. This is the particular palatal depth area we can going to reconstruct. This is something called as skin areas, and uvula also been seen. So this model is frequently used to demonstrate which are generated during the functional relation when explaining the functional relationship of tongue, uvula, soft palate, and pharyngeal wall, because it is not just the closure of the cleft, but it is the functional closure of the areas where you can able to need to appreciate the functionality of the particular areas in more detail. So this is what we are looking for. So as a conclusion part, before proceeding the cone beam CT, the risk benefit analysis has to be carried out. While we cannot ignore the risk of radiation, benefit of 3D imaging as far as treatment planning, treatment outcome, and treatment evaluation is concerned must be vetted very consciously. Whenever cone beam CT is recommended, make sure that FOV, that is focus of view, to cover the region of the interest, the voxel size, that means thinner the sections, and the recommended resolution protocol should be followed, where you are going to use the LRA technique by giving the reduced radiation dose. Compared with the conventional methods or photographs or 2D models, 3D models have been shown a valuable resource tool to assist the preoperative education of the patients, preoperative analysis by the surgeon of the defect. And also, as a part of the 3D printing, a digital model or suite of the 3D models are very common in using the surgical planning, prosthesis, maybe in future implant designing, maybe for the use of the medical education, and is nowadays widely employed by the surgeon for pre-operative planning and stimulation and to the mock surgery to avoid the complication in the future. So this is all possible because the advanced imaging techniques where we have the DICOM data and where we can, before going for the operation table, the patient is very well aware and even the surgeon is very well aware the outcome of this particular surgery. So this is what about this particular session. Thank you so much, the complete team, organizing team of the Chhattisgarh Dental College and Research Institute. Special thanks to Sir on the oral medicine and radiology who has given me the opportunity to share certain thoughts on these CVCs. Thank you so much.
It was a pleasure to attend your lecture, sir. Thank you so much for sharing your immense knowledge, and the much descriptive explanation of CPCT will definitely be beneficial even to the beginners of dental. We will accept this certificate as a token of our gratitude. Thank you, sir. Now moving forward, there is a small change in the schedule. We shall first have the demonstration session on the pre-surgical nasoalveolar molding, and we will continue the lectures after lunch. For the demonstration session, may I now request our eminent speaker, Dr. Pallavi Daivani, to enlighten us. Ma'am has completed she is an MDS in orthodontics, PhD, MPhil, Fellow in Cleft Orthodontics, Dean Academics at Lead Health Sciences, Associate Professor in Department of Orthodontics at Sharad Pawar Dental College and Hospital, Savangi, Meghalaya. She did her MDS in 2009 and PhD in 2015 and has been associated with the much proclaimed Smile Train project since 2009. She is co-convener, University Grand Commission recognized University Forum Women Forum Cell, and editor-in-chief of Journal of the Dental Research, DMIMS, and Journal of School and of Advanced Studies. She received the Young Researcher Award in December 2020 for her work in Cleft. Her talk in Orthodontic Innovation Conclave 2021 was also appreciated a lot. She bagged first position in Masters in Medical Education, MPhil, in 2022. She is associated with FDI and Smile Train for the formation of MOOC for Comprehensive Cleft Care. She is a resource person for Cleft and conducts workshops on PNAM for Cleft care in national and international conferences and also conducts hands-on for trainees. With an overwhelming innovative streak, Ma'am has 6 copyrights and 2 patents to her name, including a new classification system for BCLP to assist PSIO, pre-surgical nasal cartilage molder, a Savangi appliance, a new classification system to assist PNAM in complete UCLP in infants, new and practical approach to assess point ANS on cephalogram, sand displacement test, which is an age-old strategy redefined to evaluate maxillary palatal vault volume in cleft lip and palate cases, modified PSIO nasal stent, retentive button-free device, and the patents 2-piece flexible appliance for BCLP infant and a loop device for a plurality of teeth, that is MV loop. She published a monograph on growth in patients with cleft lip and palate in February 2020. She has 32 publications and her knowledge to the many by relentlessly conducting workshop and hands-on training related to the PNAM technique. Over to you, ma'am.
Thank you so much, Dr. Aisha, for this overwhelming introduction. I hope I am audible to everyone. Kindly allow me to share this screen. Is visible. I'm not able to stop share.
पल्लवी आवाज नहीं आ रही, यू आर नॉट ऑडिबल.
Hello, am I audible? Hello.
Yes, ma'am, you are audible.
Yeah, stop share. So, hello everyone. Sorry for the failure. I'll be first demonstrating the procedure for the PNAM, that is the pre-surgical nasolabial molding procedure for unilateral and the bilateral. Is the video audible? Is it visible? Should I start?
No, video is not visible.
I've already shared it. Should I stop share it again?
एक
अभी देखो सर.
यस, अभी चालू है.
So you can see here, this is the unilateral cleft and palate patient. This is how the nasal deformity is there. And when we approximate the lip, so the nasal dome can be evaluated. See how it appears. As soon as we approximate the lip, we can see the nasal roundness of the nostril that is affected with the cleft. So this gives us a guide that how the nasal molding should be done and exactly where the nasal stent should be placed. In short, this is how the impression has been taken and the appliance has been fabricated. So we will be looking into this in detail in the next video. The material that is preferred. Is the video available? Is it visible?
Explorer is visible.
Video is visible.
Now it is visible.
There is some delay that when I'm opening the folder and selecting a video, I need to again go to the share screen and then select that particular video. We will do that. So the preferred material for impression making is the heavy body putty. We do not need light body along with it because retention is not an issue while fabricating the appliance for the PNAM. Why it is not so? Where the thought comes in the mind, वहाँ पे तो teeth नहीं है, there will be no teeth to hold the appliance in place. Then how the retention will be there? And why the light body is not used for the for taking the final impression? The reason is we need this appliance to be as passive as possible. So once this done, the kneading of the catalyst and the the material is done. You need to adapt it on the tray, make it in an arch form, and the first thing that you need to do is allow the baby to cry loud. This position I prefer, that standing behind the baby, inserting the tray inside the mouth, and then just turn the baby upside down. That is, you need to turn the baby in a supine position. This is how the impression should be taken. Now, why we do this? Because when the baby is crying, we are assured that the airway is patent. He has not, there is no material now inside the throats because which may again affect the respiration of the baby. Okay. So, and if when the mouth is open wide, whatever is the saliva, everything, so it will drool outside the mouth. Baby will not try to swallow it. This is the primary impression that has been taken with it. I did not allow it to set because the moldings while removing the appliance and all, there are chances sometimes that the appliance, that the material may tear off, but the putty has a very good quality that it is a tear resistant material. So even allowing it to set can be taken into consideration while taking the impression. I prefer to remove it some a few seconds before so that the alveolar, the sulcus areas can be molded properly according to. So I prefer it to make a bit wide than what exactly the original anatomy of the alveolar ridges is. The video visible? Figure video visible?
Ma'am, we need to wait a little.
Now
Video
is
is
it
not
fine?
visible, ma'am.
Yeah, is it
No,
fine now?
ma'am.
Yeah. Is it fine now?
No, ma'am, video is not visible. Yes, ma'am, we can start now.
Yeah. So once the impression is been done, we pour the cast in, and the first thing that we need to do is identify the areas on the cleft cast, what areas need to be blocked. Now, why this blocking of the finger defect is needed? Because we need to create an arch form for the unilateral as well as the bilateral cases. This creation of the arch form will give us an idea exactly what will be the shape of the arch after the treatment with the pre-surgical nasolabial molding. So there is an importance of blocking the defects with the wax. It should be not too less. It should not be constricted. And the wax that is used to block, I prefer using the boxing wax. And it is moldable. It is very soft to use. We can adapt it. We need to heat it and then adapt it on the cast. So it is very workable. So whenever you are blocking the defects with the wax, make it sure that the defect is blocked at least 1 mm above the height of the defects in bilateral and the unilateral. So this is how it is being molded and fit it into the defect. Take as much wax as you need. How we adapt it to the defect. Merge it along with the greater as well as the lesser segments. The proper arch form. And this is how in the area of the lesser segment, I am applying some extra amount of the wax so that excess amount is given, the excess space is made available prior to the fabrication of the appliance. So in the procedure, see, this is how we need to check whether the arch form is being created by application of the wax for blocking the defect. So this is how you have to see. Now, because we need to expand the greater segment outside. And for that procedure, we have to do the moldings. Molding process, what comes is, we need to create the space so that the alveolar ridges can be moved in that area, and we add the permasoft liner so that the pressure is given to push the appliances. By applying the wax, initially these acts as spacer so that the first activation and the first appliance activation is when we can like omit it. So this is how cast has been prepared for the unit. You can see how the arch form is there. After that, apply the separating medium and allow it to dry for almost 1 to 2 hours. For the bilateral cases, we have 3 parts of the maxilla. Premaxilla, which need to be pushed back, and the alveolar segment, which need to be expanded laterally. So, likewise, we have to create an arch which is mostly a V shape. A blunt V shaped arch need to be prepared because we need to have space so that the premaxilla can be pushed behind and the lateral segments can be pushed outside transversely. So in this case, bilaterally close the defect. Also, as I said, that the appliance should be passive in nature. Do not want a fully, completely, tightly fitting plate in the intraoral cavity for the baby when he is wearing. So we also need to block the Vomerine defects. Here, what we are doing, we are again applying the wax as a spacer because we know that the premaxilla need to be moved back. So the spacer will give us some extra space to move the premaxilla behind with the initial forces of the lip taping and the retentive tapes. Try to close all the defects so that any sharp projections are not there in the appliance, which will hurt the babies because there is defect intraorally and the projections in the plate can even hurt. These projections can also interfere in the movement of the premaxilla and the lateral segments. These are the Vomerine defects, which are in depth, and these also need to be this is the cast preparation for the unilateral and the bilateral cases. Apply the separating medium and allow it to dry. Once the appliance is being fabricated with the heat cure and the cold cure, this is what we get. That is a unilateral appliance for the UCLP case and a bilateral appliance for a PCLP case. They are fabricated in soft cure acrylic resins, and this can be fabricated even in the heat cure acrylic resins. So coming to the fabrication of the nasal stand, we need to have, you can see here the 2 holes that I have paused the video. You can see here the 2 holes that has been made with the burr, the straight burr. So this is the place where the retentive wire will be placed for the retentive stand. So the retentive nasal stand will be acrylized into these holes in the retentive buttons. So there will be 2 stands in the bilateral case and there will be 1 stand in the unilateral case. Wire that is advised is 19 gauge stainless steel wire. So make a small hook. It can be very well placed inside the drill that has been made on the retentive button. Once it has been done, we need to check it so that it can be stable. Once it is stable, then we have to acrylize it. This is the swan-shaped wire bending that is been done for the nasal stand fabrication. So the length of the length of the retentive stand should be 5 to 6 millimeter more than the retentive button. Now, what is the position of the retentive button and what should be the length of the retentive button? That part will be covered in the lecture, but I'll again explain it here as well. Whenever you are making an appliance for any patient, so facial morphology, the amount of the fat tissues, the amount of the defect is different for every patient. Whenever the appliance is in place, the retentive button length should be such as it should not be embedded inside the lip. Not so small that it has been covered with the lip tissues. Because if it is so, whenever the patient is wearing the elastics and the tape, it may hurt the lips. So it must be projecting outside the lip so that the elastic do not touch the lip tissue and are away from the lip tissues and adapted to the cheeks while placing it and adapting it. So they should be sufficiently outside, sufficiently projecting outside and downwards for the adaptation of the of your elastic tissue, elastics and the tapes for placement of the appliance. And when we fabricate the nasal stand, it should be almost 5 millimeters more than that of the retentive button for each retentive nasal stand. How it has been adapted, and once it is stable, what I am trying to show here is you can see that the retentive buttons on the bilateral cases is divergent. They are not parallel to each other. They are not placed parallel to each other, but they are placed divergent to each other. Now there are two reasons for it. We need space to accommodate the prolabia. So we have already seen the pathophysiology and the embryology and anatomy. We know what exactly the prolabia is. So we need space to accommodate the prolabium in buttons, and therefore that space can be created by diverging the retentive buttons in the bilateral case. Plus, the second reason why we need to keep divergent was the retentive stents, the nasal stents that have been activized on the retentive button, when they are placed, the wires ultimately towards the nose will be converging towards each other. The wire parts will be converging, whereas the retentive buttons will be diverging. So both has their different role in it. So that is why the retentive buttons are placed converging, diverging. So this is how I am directing that we need to have the prolabium, and it can also help in applying the retentive vertical tape. So once the nasal stent has been acrylized, you can see here for the bilateral we have already acrylized 2 nasal stents, and for the unilateral we have 1 nasal stent. Then comes the second step, that is the fabrication of the nasal ball. So what I prefer is the sprinkle on technique for the fabrication of the nasal ball. So by drop, I add a drop of monomer on the nasal stand and I dip it into the acrylic powder, mold it, give it a shape, and again put a drop of monomer and again dip it into the acrylic powder. Now, step by step, you need to fabricate the nasal stand. You can also use the composites for fabrication of the nasal stand because they are easy They can be molded, they can be given a shape, and then light cures can be used to cure it. So they are again easy method of fabricating the nasal stent. This is what I am trying to make it in a kidney shape. Now the need of the kidney shape, why the nasal stent should be a kidney shaped ball is the depression in between the nasal sepals will be explained in detail in my lecture. The depression in between the nasal stent or the acrylic ball is to accommodate the nasal alar rim. If we keep a smooth round nasal ball and there might be a depression in the nasal alar rim tissue with the patient. To avoid that depression in the nasal alar rim, it is very important to make a space for the nasal alar rim in the retentive button itself. So this is how it can be fabricated. So this is how the nasal stent has been acrylized. We have acrylized the nasal stent for the unilateral as well as the bilateral, and it is made kidney shaped. Depression, so the placement of the nasal alar cartilage bilaterally for the bilateral case and unilaterally for the unilateral case. Now the appliance is ready after acrylization of the appliance and after the fabrication of the retentive button, after the adaptation of the retentive nasal stent and the nasal ball. Now here comes the important role. Now the next step is very important, right? The movement of the alveolar ridge. So what first we are going to do is we are going to identify the areas where the alveolar ridges will be moved. So as I already discussed, the greater segment need to be pushed inside, whereas the lesser segment need to be pushed outside for the unilateral cleft lip and palate. For the bilateral cleft lip and palate, it is the pre-maxilla need to be pushed inside, whereas the lateral segments need to be pushed outside transversely. Accordingly, we need to mark the area where the perma soft liner or any nowadays also we use the GC soft liner as well. So the soft liner should be applicable, should be applied, and exactly at the opposite side, the acrylic should be removed. So the forces and the pressure given by the soft liner, it should allow the segments to move in that particular direction. So this is how I'm directing that we need to push the greater segment inside. So this is the area where I have marked the greater segment where I need to apply the liner, and for the lesser segment it is on the palatal area where I'll be applying the liner. For the premaxilla, it is the premaxillary segment, anterior segment where the soft liner will be applied and it will be pushed behind. Whereas for the posterior alveolar segment, it is the boomerang extension where the soft liner will be applied. So, pressures can be given to push the alveolar segments. Simultaneously, just opposite to that, the acrylic will be removed to create a space. How we have applied it. Push it transversely. Soft liner that is being used in the department from GC company. Liquid and the powder. We also have many available materials. Are in one form available, so you can just have equal combinations of the catalyst for the liners. This consistency is needed for the application, and you should have a bowl of hot water for the initial setting of the soft liner. This is the hot water that I have kept aside. A sufficient amount of the liner, apply it on the area marked for the unilateral, and it should be only 1 millimeter per appointment. It should be just an application or brushing off of the soft liner that we need to be done, because the tissues need to be adapted to the new pressures. So just approximately 1 millimeter of the soft liner application should be done. So this application is done for the greater segment on the outer side of the greater segment for the greater segment to move it inside, and also on the nasal stent. Now, this nasal stent activation will be done for each week, every after 7 days. Patient will be called for activating the appliance by application of the soft liner for the unilateral, how we have applied. Keep it in hot water for the initial setting of the soft liner. For the bilateral, applied on the extensions of the humor. Both the sides, so that this application of the soft liner will push the lateral segments transversely. So this is repeated on the other side of the alveolar ridge and also on the inside of the premaxilla to push the premaxilla palatally. Now here comes the most important video that will help us to know that how the appliance has been rated. What has been done, we'll just revise the steps. We took the impression with the putty material. We checked the impression whether it has all the anatomical details covered. We poured it into the dental stone, and the cast was prepared. We identified the areas of the undercuts. We blocked it with the boxing pads so that a continuous arch form can be fabricated for both the cases for unilateral and bilateral. Okay. And then what we did, we applied the separating media and we fabricated the appliance with the fold cure, or also you can use the heat pure acrylic resin. So after the appliance was fabricated and trimming was done, the retentive buttons were acrylized exactly in the middle of the defect. After the retentive buttons were acrylized, then the positions of the nasal stents were identified, and the nasal stents were acrylized onto the nasal retentive buttons. After the acrylization of the nasal stent on the retentive buttons, the nasal balls were fabricated, and later the areas for the soft liner application was identified and soft liner was applied for the unilateral and the bilateral cases. I request everyone to please keep the questions ready. So we will have the discussion in the panel discussion, which is arranged at around 4 p.m. in the evening. So here comes the next important step, that is how to place the appliance. And for that, we need two tapes, surgical micropore tapes, which is 1 inch, and the other one need to be of 1/2 inch. This 1 inch tape, which I am holding in the video, is applied on the face, because we need to remove the appliance for almost say 5 to 6 times to clean it in a day. And every time removing the appliance, removing the tapes, we hurt the tissues and create injuries to the facial tissues of the child. So it is better to have a base tape which is 1 inch to apply it on the face, then it is very easy to remove the tape from over the tape. So this is the role of the base tape. So cut it approximately to the size of the patient's chin. Because we have some lean patients, we have some healthy patients. Now, just have a look at this procedure where we are fabricating the retentive tapes. So, take a red elastic expanded two fingers of the same hand, and with the other hand, just roll on the tape on the elastic. This is how the retentive tape is fabricated. I'll again repeat it once again. Take a retentive tape. These are the retentive tapes which will be holding the appliance. Hold the elastics, expand it on the two fingers of the same hand, and use the other hand to roll the tape over the elastic. This is how a retentive tape is. And we need two retentive tapes for unilateral as well as bilateral. Again, a repetition, expand it, and then use the other hand to so these are your two retentive tapes. Base tape applied the chip, the initial tape which should be directed upwards. The base tape is directed upwards, covering the complete face. So in the initial days when the baby is just 1 month or just 7 to 8 days, you need to have a very small tape because that time the tissue is also very lax. It is not firm, and the tissue also appears to be like all collected. It appears to be like shrink sometimes. Now this baby is quite old baby of 3 to 4 months, and therefore there is tightness in the muscle as well. Therefore, it is been the tapes are placed very well on the face. So this is how the base tapes are placed. This is the lip taping. Now before we start for the lip taping, I would like to tell you here. Apply the lip tape on the cleft side first. Apply the lip tape on the cleft side first. Why we need to do this? Because as you can see in this image, and I will also discussing the cleft morphology in my lectures, in unilateral cleft lip and palate, what happens is the nose is shifted towards the non-cleft side. Because of the cleft in the lip, the tissue pulls the nose towards itself, and the nose is always shifted to the non-cleft side in the unilateral cleft lip and palate cases. And what is the job of the lip tape? You need to pull the shifted nasal philtrum and the lip philtrum and the nasal columella in the midline. So what we need to do is apply the lip tape first to the cleft side cheek. Then just pull the lip towards the midline and close you can stick the lip tape. So this is how it is done. I am applying it on the cleft side. Now see how I am just getting the tissues in the midline. Just repeat it again. Apply the lip tape on the cleft side. Then push the tissues or pull the tissues in the center and just stick on the lip. Take the appliance. Make it sure that the lips are not inside the appliance, but they should be outside the appliance. The tongue is not inside the appliance, it should be below the appliance. And once it is done, place the appliance and use retentive tapes. Once the cheek tapes and the lip taping is done, insert the appliance. Position the nasal wall. You can see how the nasal dome has been lifted. See how the nasal dome is lifted. Check whether the lips are not entrapped inside the lip, the plate, and place your retentive tapes and stick on the lip tapes and the base on both right and left side. Now, how much must be the force of it? It should be just 2 times the original size of the elastic that you are using. Red elastics are not always compulsory if they are not available, but whatever elastics are using, you should be 2 to 3 times at the max the original diameter of the elastics that you are using. How it is written on one side and no. This is the complete assembly of the PNAP appliance in the unilateral cleft lip and palate patient, where we have the base tape, we have the lip tape, we have the appliance with the retentive button and the nasal stent with the nasal ball, and we have retentive tapes with the red elastic holding the appliance. So this was all about the appliance fabrication, use of the retentive tapes and the appliance, the retentive tapes, the button fabrications and the application of the plates and the tapes. It is also done for the unilateral as well as the bilateral. So bilateral, there will be 2 retentive buttons and the 2 nasal stents, and both the retentive tapes will be on the right as well as the left side. So, Ajay sir, the questions will be like answered at the end of the session, the evening tonight.
Yes, yes, we'll be having question answer session at the end because we are running late. So
Yes.
we have planned for it.
I hope I tried to cover it.
Yes, but you are also available at the question answer session.
Yes, I will be there. I'll be definitely there. Thank you so much for changing the schedule today. It was really very appreciated. Yeah, right. Thank you so much.
Thank you, Pallavi.
Thank you, ma'am, for sharing your clinical tips and expertise in the form of this very interesting demonstration. We have been listening to eminent 5 speakers deliberating in the areas of comprehensive management of cleft lip and palate since morning. All these valuable insights gave us a new perspective that one should adopt in their practice. A brief pause for lunch is much called for. We shall resume the webinar sharply at 2 p.m. I request all the participants to
Before that, we'll be delivering the certificate for video demonstration to Dr. Pallavi. So
yes.
I request Dr. Pallavi to kindly accept the certificate of appreciation for the video demonstration.
Thank you, sir. Thank you.
Yeah.
Thank you.
Yeah. Now we can break for lunch, and we will be resuming our session at 2 p.m. I would like to mention that same link will be used for today's afternoon session as well as tomorrow's session. So kindly join with the same link which is provided in the WhatsApp group. Thank you.